Hey, Rukia, can you give me video access, please? Thank you.
Okay, should be good.
Perfect, thanks. I'm gonna give Monique, or if you can give Monique panelist access, I think she's gonna present, I believe, her slides, and then I'll let her share her screen so that she can move it forward when she's presenting. Good afternoon, Monique. I just want to double check that you'll be, is it you or one of your students that's going to be presenting the slides this afternoon?
I will be presenting.
Okay.
But my students, this link that I have does not work. It says it has expired. That was one of the.
Okay. Let me put it, I'll put it in the chat for you to share.
Yep.
Right here. Oh, no. Copy link. Okay, and then the passcode. There we go. Okay, did you get it, Monique?
Okay, I have to rewrite to all the students, right? So it will take me a little bit of time because I have to go back to Lulima and to everyone.
Okay. Oh yeah, and then blast the email. Got it.
Yeah.
We have a little time. We have a few more minutes.
And then, what did you say? Passcode.
Hey, I'm not Thomas Lee. I don't know if you can hear me.
Oh, hey, sir. I must have given you the link that meant directly to that went to my account. I'm gonna move you to the attendees, sir, if you don't mind, and then thanks. Rukia, can you move the other Thomas Lee to the attendees? I copied the wrong link, so I have a twin right now. Thanks, Rukia. Actually, no, that might have been Monique. Actually, I think I might have sent you the wrong link. Rukia, can you send Monique the actual link? I think I sent my personal link, and it's gonna log in as me. And then it's gonna get very confusing with like 20 Thomas Lees. Or it may be too late for that.
One of the section got your link, unfortunately. So.
Oh, that's okay. I think they can.
And same password, right?
Yeah, same passcode. Yep. I'm sure they can change their names, so they're more tech savvy than I am. Good afternoon, everyone. Thank you for joining us this afternoon. Happy second Tuesday of, or third, excuse me, happy second Thursday of January and of 2021. Good to see some familiar names joining us. And then if you notice multiple Thomas Lees, that was an error on my part. Happy to have hopefully more than a few of Monique's students joining us for today. And if students, if you enjoy what you listen to and what you hear, we'd love to have you moving forward. We're gonna wait one more minute and then we'll get going on our webinar today. Some housekeeping things. If you have questions throughout any portion of the webinar, please go ahead and put them in the Q&A, and I will moderate if I'm not presenting, and if I see it, then I'll go ahead and answer them to the best of my ability. So please feel free to utilize that. And if there's a comment you want to add, just raise your hand, and Rukia will give you voice access as well. Okay, so welcome everybody to our 14 January HiPAM Community Work Group webinar. We're going to go ahead and get started. Starting with Japan, we like to go outside in. So understanding that we have a lot of tourism eventually, in the past, and moving forward, we'll hopefully get more tourism from Japan. We've been tracking this, I want to say, since November. And we thought that it was going to decline and stay pretty steady. But as you can see from this slide, they have continued to increase on their daily and 7-day average cases. We're seeing a slight downward trend, hoping that's going to continue, but we'll wait and see. There's a report from their Ministry of Health, I believe yesterday, where they identified another variant mutation. I don't know if, I don't see her on, but we saw another variant. They identified another variant that's similar to the UK and South African strain. So it's a new Brazilian strain they identified from some of the returning residents from Brazil. So we'll need to see how that impacts Japan. Moving to a national overview, definitely a slightly downward trend for the cases, but for fatalities and hospitalizations, once again, understanding that there is a lag in the impact of hospitalizations, ICUs, and fatalities, we are starting to now see the impact on that particular, on those particular metrics. Thanks for that question, Tom. Definitely we'll address that. Probably not be able to get you that answer today, but I'll work with Monique to see if we can provide an answer to that. Moving over to our state level overview, highlighting 5 states that have a lot that account for the majority of our tourism, and also where we know our residents typically tend to travel to and return from. Arizona and California on this slide, you can see that their cases had a slight downward trajectory a few weeks ago, but are both trending up. California, once again, has identified that UK variant, and I believe Arizona has as well. Nevada was doing well for a good period of the end of 2020, but unfortunately, once again, mirroring much of continental United States, is now trending upwards, as is Texas. Texas, hopefully, the slightly downward trend will continue and it's not some sort of blip. But as we hear more and more, and as the rest of the continental United States ramps up their genetic sequencing and surveillance, we suspect that this new strain from UK will become the prevalent strain around March or April. At least that's what the CDC suspects. So we know that there's about a 50% increase infectivity for this UK strain. Thankfully, no increase in mortality or morbidity, but that's something to keep in mind, as we haven't had a break from this most recent surge and increase. Moving on to our Hawaii specific overview, cases per 100,000, definitely Maui County, Honolulu County, and then the overall statewide average is above 10 cases per 100,000. Looking at our percent positivity rate, that 3% is kind of our metric that we use, to see to move from tier 2 to tier 3. One of those one of those two metrics besides that 7-day average for Honolulu County. You can see that for Maui, Maui and Oahu County, as well as the statewide percent positivity, above 3%, though it is worth noting that for the state, as for Honolulu County, we have come back down below 4%. For a time last week, we were at 4.4, 4.5%. So that's good news as we continue to move away from the holidays, Christmas and New Year's, and hope to see that trending down. And hopefully that means that we're beyond the holiday surge. But once again, as travel continues to increase, we will continue to be cautious. Looking at a national trend, I believe 4 or 5 days past the new year nationally, we had over 1 million travelers via the air. So once again, that's something to note for Hawaii's situation. Moving on to the vaccine efforts within the state, I believe I saw updated numbers were closer to 50,000, if I'm not mistaken, for more recent numbers. But from what's been posted, currently the state is a little over 40,000 shots in arm. Now we're not sure if how many of those are for the second dose, and therefore meaning how many are fully vaccinated. But once again, it's good to see our efforts moving forward. And for those who may not be as familiar with the vaccine effort, that 94, 95% efficacy protection against COVID for the Pfizer or Moderna vaccines only comes into play 7 days after that second dose. So once again, that's important as more and more people get in, as we increase our education efforts to pass that important information on. Testing turnaround continues to be good. Even though we were going through that spike the past couple of weeks, continuing to show that we have a very good turnaround for that 24-hour turnaround especially for those that need to stay on island. Moving on to our HiPAM forecast, looking at our cases, you can see that our blue line, our realistic, does show a slight increase, understanding that while there may have been 200 to 300, we saw cases in the 200 to 300 level for the state last week. The reports from our partners at DOH are showing that a large number of that, at least on Oahu County, are still due to the Halawa clusters. So while there is still probably some escape of that transmission from that facility to the community, we're not translating that number into a massive increase, though our pessimistic does have us continuing on this trajectory that we're on, and we're hoping that it'll come down as more and more people continue to get vaccinated. As a result, our hospitalizations and ICUs reflect what we've seen in our historical cases with that 1 to 2 week lag. Though more and more data and updated research shows that we're figuring out how to better treat initial cases within their 2 to 3 day symptom onset, and really not relying on ventilators and those more extreme interventions. And fatalities, thankfully, continue to stay relatively flat. And one thing for our new members, you may be wondering why there's so many of these gray lines. What that is to show varying levels of other projections compiled by the CDC in terms of where those different models and projections have Hawaii going. So you can see there's a wide splay, and there's more nuances to that, but to show that you have 15 different modelers, you're going to get 15 different responses, and we try to hope that we're somewhere within that range, understanding that we try to tie in as much Hawaii-specific information as possible. This slide just kind of goes over what you saw in the previous slide, but just in a numerical format, and I'm not going to spend too much time. A side note, if you want to dig deeper into our slides, they are posted currently already on our HiPAM website, hipam.org/join, and you can download this today's slide deck, and then our recording will be uploaded at the conclusion of today's webinar, and you can view all of the previous webinars at your leisure, especially if you have nothing to do on this long 3-day upcoming weekend. So spend some time on the science highlights. There, as always, there's a lot of information coming out, and even I have a hard time keeping track. I highlighted 3, and there's one more that I wanted to bring to your attention that didn't make the slide. That came out today. So the first one is CDC and HHS issue an order on 2 days ago requiring a proof of a negative COVID-19 test or documentation of recovering from COVID-19 for travel into the United States. That's going to start 26 January, so in a couple weeks. And then convalescent plasma antibody levels and the risk of death from COVID, that was published in JAMA, in the New England Journal of Medicine. And then a New York Times article looking at the CoronaVac COVID vaccine, one of the many vaccines developed by the Chinese government. And then the fourth one that's not on here that I wanted to highlight is the results of the phase 1 and the phase 2 Johnson & Johnson vaccine that just came out today, published once again in the New England Journal of Medicine. So I'll speak to that at the very end. So if you weren't aware, starting January 26th, if you're returning into the United States from an international country, regardless if you are a foreign national or if you are a US citizen, you have to have a negative test, and more details can be found on CDC's website, no more than 72 hours prior to that departure time. And currently, as it stands, you need to have a physical documentation of a negative test or a documentation of being recovered from a provider, though the individual airlines will be working on an electronic version of this. And what's interesting is they are also accepting documentation of someone who has recovered from COVID. However, there is nothing that covers vaccine, those who are fully vaccinated. So there's nothing yet, but I'm sure as more and more people get vaccinated, they're going to update that guidance. So once again, 26 January, that is something to keep in mind for those that may be traveling internationally and coming in. And also for Hawaii, right, we have a lot of international tourists, but that's not going to impact us too much because Hawaii has already had something similar for the past few months. There is a study published a few days ago, once again in New England Journal of Medicine, where they looked at a retrospective study of a little over 3,000 patients, where the primary outcome was death within 30 days of that plasma treatment. And and it's important to note that majority of these study subjects were not subject to mechanical vents. And the big highlights is that transfusion of plasma with higher titers were associated with lower risk of death than transfusion of plasma with lower titers amongst the non-vented patients. And this is also after adjusting for age, gender, and a bunch of comorbidities or confounders. So that was actually really good to note. Of importance for our clinicians on the call, additionally, transfusion within 3 days of diagnosis resulted in better outcomes, which makes sense. The sooner you catch it, the better outcomes. And we've seen that with other therapeutics as well. Once again, if you have any questions, please put them in the Q&A, and I'll be sure to get to them. Moving forward, once again, and this also impacts us at a global health level. You know, the major vaccines that we've seen are Moderna and Pfizer, and then AstraZeneca and Johnson & Johnson in terms of the major players in the vaccine space that grab the headlines. But you know, a lot of the first world countries have already purchased and tied up a lot of the initial and secondary allocations, and that doesn't leave much of an option for our emerging countries, which is huge from a global health perspective, and also for Hawaii with where we are in the Pacific. So you know, these countries are left to look for alternative vaccinations and vaccines, and CoronaVac is one of the many Sinovacs vaccines coming from China. The initial efficacy rate was 78%, but was just downgraded by a university in Brazil. And that's just slightly above the rate that the WHO deems useful for a vaccine. Important for us to track that at least 10 countries have signed purchasing agreements for various volumes of the vaccine. And we want to make sure that while we do push the vaccination across the world, we're giving them a good product. So this is just important to note as we move forward. And then the last slide, I'm just going to brief by exception on our last science highlight. The results from the phase 1 and phase 2 Johnson & Johnson vaccine trial are definitely promising. Remembering and reminding folks that the focus of the phase 1 and phase 2 is mainly safety and not and efficacy in terms of just getting an immune response. And for safety, the majority of the symptoms and side effects abated within 24 hours, and those main side effects are soreness in the arm where you got the shot, fever, malaise, tiredness. So nothing new in terms of our side effects, and it's once again positive data. And as we continue to educate our public about concerns about side effects, this adds to the growing data that we have for the safety. And then in terms of having seropositivity conversion rates, from what they showed, they tested both a single dose and a 2-dose regimen. And no matter for all of those different testing regimens, just a single shot for a low dose and a high dose, at 71 days after that first shot, there was 100% seroconversion. So there's really good news on that front. And Johnson & Johnson is big because they're trying to push just a single dose vaccine versus the Moderna and Pfizer, which is a 2-dose. So just wanted to make that aware. I'll add that to next week's slide. I won't brief it, but I wanted to just update this since it just came out today. Tom, you're absolutely right. AstraZeneca is one of those quote unquote less expensive, but I believe that's a lot of those doses have also been spoken for also by first world countries. So the more developed countries. So a lot of other countries are having to turn to lesser visibility vaccines. If there's no other questions, I'm going to turn it over to our HiPAM colleague, Dr. Shiba. And Monique, I'm gonna stop sharing and let you pull up your slides.
Thanks, Thomas. All right, so I'm going to try to speak as quickly as you, as fast. I'm not sure I can do that, but I'll try so I don't keep everybody until very late. But this is an important topic of vaccination. The simulation that you're going to see today, there's hot from the oven, if I can say. That means that we are starting to work on that. And there is a lot of questions. There are many more questions to be asked that will be provided. So I also would like to say that this is a teamwork, and especially Sasha Markovichenko. He's one of the graduate students in the med department, and he has been running a lot of the simulation over the last 3-4 days that you're going to see today. There is a lot of hit and miss, and they're still computationally quite expensive. So it takes a lot of time. I'll explain a little bit where they come from. So let me go a little bit about the presentation. So I want to backpedal a little bit and discuss modeling briefly so that we understand what we see and why we see that. The focus is on the vaccine. I'm going to introduce the agent-based model that has been used for the simulation. I'll talk about the parameters that we're assuming, the variable that we're playing with, and then give some results. And again, the main thing is going to be open question and for people to be able to ask, and probably me not be able to answer, but we have to try to come up with scenario and what are the main simulations that we want to carry rapidly eventually. So just, I don't know, I'm completely new to the field of epidemic forecasting. To tell you the magnitude of how far I was, not even a year ago when my chair came to me and he said, you know, I think we're going to be teaching, we're moving online teaching, and I think the fall will be online as well. And that's impossible, we'll be fine. And there is absolutely no way that fall 2020 would be online. And now spring 2021, we're online. And I'm the one that says that 2021 might have us regret 2020. So this is to tell you how far I came and why is it so challenging? I had actually no idea. If you take, for instance, medical imagery, which is hard, and you are trying to contrast imaging problem using nuclear magnetic resonance, then it's actually a very well-posed problem. You have a clear optimization cost, you have clear physical equations, and you don't have the human component, or like if you want to send a spacecraft or an underwater vehicle, then you're minimizing a very specific cost. If you want to do economics, you have production, consumption, but modeling a pandemic, let me tell you, it's a completely different beast. And there is a really nice article that highlights the fact that it is harder than weather forecasting, and that weather forecasting modeling is actually more advanced. And you know that we cannot like predict weather, that it's really difficult, and we cannot predict that more than a few days ahead. So the reason why it's so difficult is that because human behavior governs the equations, and this is impossible to model basically. So what are disease models? There are mainly two categories of disease modeling. The first one is compartmental, the second one is agent-based model, and we've been using both. And the simulations that you are going to see today are based on both of the models. Another issue is that data come from disease surveillance, and this is limited. There is a lag, it's expensive, there is privacy, you don't have the data that you wish for. Then there is a lot of crowdsourcing that come into the picture. It's really hard. There is massive amount of data, but still technology has never been as advanced, and it seems that we're still hitting a lot of walls in order to understand what's happening. So what can a model do? That's very important to understand, so that you ask the right question. If you ask a question that a model cannot do, then that question is mute, and then it's frustration. So making a good model for pandemic is difficult. That comes from an article like from Maggie Kurt, and it's actually Thomas that sent me that article very early on, and I thought she was very point on, right? So using it is even harder than setting it properly, because there is limited data, and because people are very, very complicated, and they are driving the virus, the spread of the virus. So what can we do? We can understand the past. We can look retroactively what happened. However, that does not help in predicting numbers in the future, right? We can do what if scenario, and I think this is where modeling is very efficient and can be very useful. It is, for instance, okay, if we do that mitigation measure, this is what's going to happen. If we vaccinate in that order, that amount of population, it's more efficient than to vaccinate in a different order or in a different variable. We're going to see, I'm going to make some assumptions also on the vaccine that are known, and that's going to help us a little bit to know what has the biggest impact and what we need to understand. So that's sensitivity analysis and the type of question, who should receive the vaccine first. So what can they do? Unfortunately, a lot. They can do a lot, but there is a lot that they cannot. And something that has been very frustrating to people is that we cannot predict accurately numbers. And the disease evolution, because there is that human component. If tomorrow the states decide to change the traveling law, the law for travel, and we block entrance, then the disease is going to evolve completely differently. If tomorrow people decide to take off mask, then the disease is going to evolve completely differently, and that's something that you cannot actually, those uncertainties are huge, that's what I'm trying to say. So people tend to get hanged on the numbers. That's very difficult. When I show a simulation, people say, oh, so in April, we're going to have 100 daily cases. That's not what it predicts. We're comparing different scenarios. That's what we do mostly. And please keep in mind, so modeling, one of the, for me, the poster child of modeling is really that flattening the curve that made its way through the government, through no scientist people, everybody has heard about flattening the curve. I have a little image here on the right that's, you have the exact same phenomenon with climate, by the way, and weather. So we are in the same course of flattening the curve for climate change, which is sort of interesting. And why is it so limited? Again, that's unclear, and that should be our job to modeler to do, to have more than one poster child and more than one notion like the reproductive number that can be really popularized and that people can use. So here, that slide is about COVID-19 vaccine. Well, I'm a mathematician, so I don't know really a lot about the vaccine. I don't know how they work. I mean, I know I've listened to my colleague. I've listened, Margaret last week gave a very good talk about the new strain, and I listened to all of that, but I have zero expertise in order to sharing any content about that. So I'm going to leave those questions to people that have the expertise. We're going to
Monique, it appears that we're not seeing the change in the slide. We're still showing the first slide.
No way.
So it's still showing the PDF with all your tabs.
Oh, really? Okay, so that's terrible.
Okay, yep, we're good now.
Yeah, I was on, okay. All right, so this is when I was talking, that's the highlight. This is about the, sorry, then I'll try to go a little fast. This is when I was talking about the different, the epidemic forecasting. Let's see. This is what epidemiological model can do, what they cannot do. This is the old, this is the epidemiologic flattening the curve with the climate change. This is the fact that I'm not going to talk about like any biology behind the COVID-19 vaccine, but I'm going to dive right into the modeling. So we are using an agent-based model. The agent-based model that we are using is called CoVASIM. Co is for COVID, A is for agent, and SIM is for simulator. And so what it is, it's an open source model actually that projects the epidemic. So you have here, and as I said, it's an agent-based model, okay? So it does require quite a lot of computational capability. Here you have, it includes demographic information on age structure, population size, realistic transmission. I'll give more information about what we're assuming, what we're not, what is difficult with using that agent-based model. Again, it's an open source, so everybody that wants to use it can use it. Now it is hard to use. Okay, you have to install, you have to know coding. Everything is in Python. It is no user friendly at this stage. So you have to be quite proficient in coding. So what does it do? So it simulates the state of individual people. So you have agent, and then it is based on a probability that given an agent at a given time, it has some probability to change its status. Like for instance, to go from susceptible to being exposed, or to go from severely ill to critically ill, or to make those advancement and progression into one stage to another one. Those are, this is made by per agent, and it's probability based. So the limitation is that it's not user friendly again, so it's really hard to use. There is quite an investment. Data feeding is difficult. So we were given the virtual population for the island of Oahu, and we've been using that, and that was very useful. Then now we are like a few months after the start of the pandemic, after the first case that was discovered on Oahu. So we wanted to do data feeding to try to understand the transmission, some of the parameters that we're using. It was difficult, so we did that with a compartmentalized model and we extracted the value, basically the cousin of the or not, and then we used that into the agent-based model to run different type of simulation. It's computationally expensive. As of now on its laptop, the student, it takes about an hour and a half for one simulation. One simulation is in the code because it's a stochastic model. And therefore, to get one simulation, as you're going to see on the screen, you run between 6 and 12 simulation and you average those. Because every time you restore, you have a different outcome. Adding new population attribute is difficult. For instance, ethnicity, profession, that was not directly embedded into the COVACIM. Ethnicity is important for Hawaii, so that's something that we might want to put as an attribute, but again, it is not easy to do, and it's not well suited as it's currently done to include travelers. So we have used the compartmentalized model for travelers. So let us dive now into the vaccination plan. So where are you in the vaccination timeline? Hawaii is following the plan mostly from the CDC in terms of their phases. And here, this is more numbers, and I'll crunch a little bit those numbers, and then we're going to see some simulation, and I'll say a little bit about the outcome that we have seen, that the issue, and what seems to be important and not. So this is phase 1A, phase 1B, phase 1C, phase 2. The simulation that you're going to see there on Oahu, from the numbers that we see, it seems that the vaccination is going to be more difficult on Oahu to stay on track. The other, my understanding is, for instance, Maui is ahead of where we are on Oahu. I don't know for the other island, but it seems to be following, of course, a little more rapidly than here. So let us look a little more into the detail about those numbers. So if you look ideally at vaccinating the entire population, 100% of the population, so phase 1 would vaccinate 70% of the population, a little over 70% of the population, which means that we would basically have herd immunity when we are done with phase 1. This will be assuming that every single agent in that population is agreeable to be vaccinated and is doable to vaccinate that person with 2 doses. So some survey and some other data have suggested that there is a little bit of reprehension about getting vaccinated, and that maybe looking at 50% total of individual count to be vaccinated during those phases is maybe a conservative first take. I'll compare both in the simulation, as you'll see, but if we were to vaccinate half the population, this is the population aged 16 and older, assuming 2 doses per individual. And so if you assume that you're vaccinating 100,000 doses per month, that means 50,000 individual. Well, okay, so here the calculation is wrong. So 50,000 individual, that means it will be about 10 months to vaccinate everybody. Okay, so this is, well, I don't think we're looking at everybody being vaccinated by the end of April into the island. All right, so let us look a little bit into the model and some of the assumptions. It's always really important to highlight what are the assumptions that were made, so we understand what the simulation actually say and what they don't. So in the model, every agent, so every individual it's been assumed 4 types of contact. So it's the households, the school, and the work. So those are assumed to be fixed contact. It is assumed that you are living with the same people throughout the pandemic, that you're not changing school, and that your colleagues are the same. And then there is like the 4th type of contact that is assumed between the agent is community, and then that one is random. Then there are some, based on knowledge that we have now about COVID, like there are some other assumptions that are being made on the parameter, like the average time from exposed to symptomatic is 4.6 days. Now this is just the average time. Every agent has a different value that is assigned, whose mean is the 4.6 days, but it comes from the normal logarithmic distribution The average time for symptomatic to severe cases, 6.6 days, and from severe to ICU is 3.0. That's what they took in the Covaxin. We didn't touch that. The average to recovery is 8 days if you're asymptomatic or mild symptom, and then 14 days if you have more critical or severe symptoms. And then the fatality probability for aging is distributed by age, and of course it grows as you grow older, and it is applied once you reach a critical stage. It is assumed that symptomatic individuals are isolated until they're recovered. Transmission is reduced by 80% once you're isolated. If an individual is exposed to a symptomatic person, then there is some type of contact tracing that is in the model that was added by us. So there is 15% probability that you go through quarantine through contact tracing if you've been exposed to a symptomatic person, and the average quarantine days is assumed to that at which you're caught and you go into quarantine is assumed to be day 5 of exposure, and the reduction of the basic transmission then is assumed to be 80%. And the people that recovered, then they are no susceptible to the virus anymore. So those are the assumptions that we have into the model. So now what are we going to be playing with with the model? So some of the variable. More assumption that we've made and this is fixed into the model. So we are assuming that vaccines reduce symptoms by 95%. That means in every simulation that you're going to see today, you're assuming that the individuals are receiving 2 doses. We haven't at this stage started putting a real scalpel and saying you get the first dose here, you get the second dose 3 weeks later, and then 7 days after. And we haven't done that. We haven't gone at that level of deconstruction, but that's possible to be done. Then if getting symptoms when you're vaccinated, because it's still possible, okay, at 5%, but then it is assumed that the symptoms are never going to go into the severe category. Okay, so this we assume it is something that's set. And again, the 95% changes from vaccine to vaccine, and those are things that we might be able to take into account as we move forward. Like, remember, this is the first, I'm like showing you the first batch of simulations that we have done onto vaccine to get very quickly feedbacks and suggestions for different scenarios. So the variables, so things that are unknown, at least that we do not know, is the susceptibility of vaccinated individual. Do you still catch the virus and you're just not showing symptom, or is there a reduction in your susceptibility? Then transmissibility, if you have the vaccine and you get the virus, do you still transmit the virus to other people? Or is that not the case, or is there a reduction? Then we can play with the age of vaccinated individual, play with different scenario. And then of course you can play with the fact that people will want or will be non-receptive to have a vaccine. All right, so then the rest, I'm basically going to show you some simulation and some scenario. Here is some vocabulary. So new diagnosis means that you're symptomatic. That's the curve of new diagnosis means you're symptomatic. So you've basically been tested and diagnosed. Infection, it shows asymptomatic plus symptomatic. Then severe cases, it is hospitalized people. And this is as long as beds are available. We haven't reached that limit on Oahu. So if you're severe in our simulation, you assume that you're hospitalized, at least for the past. As you'll see for the future, we might, there are some scenarios that are going to push us above the limit, and critical cases means that ICU also, as long as beds are available. All right, so more data that we are using for the simulation. So the base transmission rate. So again, that's the cousin of the R naught, of that famous R naught that we're using. they've been determined using a circumpartmentalized model. And here are the transmission rates as they've been varied. And this is a result like the transmission rate have varied depending on the mitigation that were in place. Like we started with a 1.6 and then we went to a 0.2 because there was the lockdown. And then it was reopened and and other lockdown. But since October 15, for the simulation that we are going to see, we're using a transmission rate, sorry, of 0.918, which is smaller than the two surge that we have back in April and then back in August. It is, however, a little larger than when we started going down, which makes sense. So we have actually, with the SEER model, we refined a little bit the transmission rate. You'll see this one is a little bit of an overkill at the beginning after October 10 because we were plateauing, but then the numbers lately have been going up, so it ends up being a pretty good fit. So we assume that 50% of the individuals in the various phases get vaccinated and not 100% of the count that you see on the vaccine plan. And then we assume that the duration of the vaccination is 3 months. So mostly we're looking at phase 1A and phase 1B of the vaccination. Okay, so it is healthcare personnel, long-term care facility, and then adults 75 years old. So phase 1, phase 1A, phase 1B, we're looking at different scenario once you completed those two phases over a period of 3 months. So here is the first scenario, the data for the first scenario. That's sort of the worst case scenario. I mean, it seems like we're going to give you an even worse case scenario afterwards, but here you are assuming that if you get the vaccine, you're not developing symptoms. However, you are still susceptible to get the virus. It's not reduced, you're susceptible like if you didn't get the vaccine. And if you get it, you would transmit it in the exact same way. So the only difference with the vaccine is that you're guaranteed to be asymptomatic, but that's the only change that would come into the model. So phase 1A plus 1B, we are assuming 100,000 individuals have been vaccinated, and we are assuming 2 doses. That means 200,000 doses were administered into the span of 3 months. That's the assumption that we have. So you can see that you do not see the effect, the impact of the vaccination. I mean, if you don't do the vaccination, then it goes further up, of course, but we're still on an increasing ramp. So if the vaccine does not reduce susceptibility nor transmissibility, we have to use mitigation measure in order to be able to not grow to like 600 daily cases. Otherwise, we keep growing. So scenario number 2, I mean, people assume that there is some reduction in susceptibility and transmissibility. So we are in the exact same scenario, but here we are assuming that we have reduced transmissibility. Okay, so we are assuming that transmissibility is reduced by 75%, so quite a lot. Not only you're asymptomatic, but the viral load, or I'm not sure what makes the transmit is lower. I'm not a biologist and I'm not a doctor or anything, so I'm not sure, but maybe the viral load is reduced and then you transmit less. So bottom line, we assume 75% reduction in transmissibility. Same data for everything else. And you can see that for a little longer, we're still going to go up, but eventually throughout the vaccination of phase 1A plus phase 1B, that will be somehow in phase 1B, we are going to start decreasing and we're going to see the impact of the vaccination. So one important thing to keep in mind in all of this is that we're keeping mitigation measure the same 6 feet away. We're keeping the fact that people have to keep masks. We're keeping the beta as it is now. So this does not allow for any relaxation into the mitigation that could bring up the economy. So we are assuming that for the next 3 months, it's statical into all of that, right? So, and then you can see, I'll crunch a little better the numbers, but that's the scenario number 2. So now you can see, why did you choose transmissibility versus susceptibility? So we actually did run the simulation, assuming susceptibility is reduced by 75% instead of transmissibility. It's very similar. And then we assume transmissibility reduced by 50%, susceptibility reduced by 50, which akin to the same 75% when you multiply them. And it's, again, very similar results. So we just left it at transmissibility. The next scenario, we reduced transmissibility and we decided to try, what if we vaccinate 10% of the younger population early on? Okay, is this going to have an impact? So if you look carefully, it seems that it's pretty much statical. It does have an impact. I'll give you the percentage in the next slide, but because we are vaccinating a lot of people, and this is not enough to actually make a huge impact over the transmission of the disease. So here are the data that we have. This is what we have when we started the simulation, and this is afterwards. So remember, scenario 1 is the worst scenario, where all the vaccine does is make you asymptomatic. Scenario 2 is the scenario where not only you get asymptomatic, but your transmissibility, your capability of transmitting the virus is reduced by 75%. Then the percentage that you see here is by how much you reduce each category. So we would reduce infection by 26%. We would reduce severe cases by 23%, and that can really have an impact on overwhelming the hospital and the ICU, and we would reduce death by 19%. And the last reduction that you have here, that is about 5% above, you're reducing 5% more in each category after 3 months, is assuming that we vaccinate at the same time 10% of the younger generation. Okay, so I have one more. I have 2 more scenarios. So this is scenario 4. And so that's sort of the doomsday scenario. This is assuming that the new strain comes and hit us. So we are transmissibility. Again, this is exactly the same thing as scenario 1. So for scenario number 4, we really went with an overkill with the new strain, but we wanted to show, and we can do that in a little better way, but we wanted, those simulations again are from yesterday, 6 p.m. So, but we wanted to show what the impact of the new strain can have. This is assuming that transmissibility increased by 50%. So again, it's another overkill because it is assuming that transmissibility increased by 50% even after you have the mask and mitigation measure. So maybe a better number to use would be maybe 30%. If the new strain is like 70% more transmissible, that's going to be reduced through the mask and everything. I assume that when they say 50 to 75% is just like the viral load that comes from like without any mitigation. But you can see this is like suddenly in February, when suddenly we are assuming, again, doomsday scenario, the new strain completely take over and we have that increase in transmissibility. It's completely skyrocket. And there is just absolutely no way that phase 1 and phase 2 is going to be able to address the new strain. Even if we assume smaller percentage. Again, do not get hang on the numbers because this is like we overkilled with that new strain, but that was sort of the goal. But the bottom line is that it can really be a ticking time bomb. Like comparing scenario 4 to scenario 2, we see a 289% increase in daily cases and a 204% increase in death, assuming that nothing else is changed in terms of mitigation measure. So the take home here is that a higher transmissible strain has the potential to be more devastating than the fact that the vaccine would still allow you to be susceptible and transmit the disease. So the new strain is really something that needs to be looked at. And then the scenario 5, so this is the scenario, sort of a little bit the ideal scenario. We're vaccinating 100% of phase 1 and phase B. That means we are vaccinating 200 individuals, 2 doses, 200,000 individuals, sorry, it's not 200. So that means 400,000 doses administered in 3 months. So that's, I don't know if it's a very realistic scenario, but then remember what, then we can really reduce, so we can really reduce by about half. Like we are administering twice as many vaccine, and we are actually reducing by almost half the infection, the death, and the hospital beds and ICU beds. So really rapid mass vaccination is something that has to be done. There is absolutely no question about that. Remember here, we are only talking about phase 1A and phase 1B. Then this is rapid mass vaccination is important. It has to be done. If we have the new strain, it might not be enough. So this is sort of the takeout. Then some of the open questions that were not addressed here. Delay second doses. Vaccinate only 1 dose and assume less reduction in symptoms, 50%. That's unclear how it's going to play out with different scenario. Young adults, there is some discussion about the fact that they should receive half doses and be as well protected. So if that's possible, that is going to allow us to vaccinate at a larger speed, dilute doses. So the impact of new, more transmissible strain, I think that's that it's not a strain, it's a strain that I think that's really for me the red flag. The impact on hospital bed. So this is something that we can get from the data. We just haven't had time. And then the impact on economy. Here you haven't seen into any of those simulation some mitigation measure trying to relax what is going on, trying to have more people going into school, and they're augmenting some of the contact, trying to have people like colleges to open, so increasing the amount of contact in order to be able to help the economy. That's not in those, and if we were to do that, then we would have to ramp up vaccination even more. So I think for now, that's what I have. So I'm going to stop sharing my screen, yeah?
Oh, thanks so much, Monique. We have a couple questions, yeah. I believe, from one of our state partners. For the first one is, for all the scenarios, are we assuming that everybody's getting vaccinated on the same day?
No. It's some of our scenario are unrealistic, but not that much. You see the vertical line that you have here? This is batch of vaccinations. So we did it into batch. So we assume that every week there is a batch of vaccination that is happening.
Perfect, thank you. And then a follow-up question for scenario 4. Is the start of the new strain, the UK strain, supposedly a new strain arrives in Hawaii, or a new strain takes over as dominant strain? So I guess that's more of an epi question in terms of the first time it's recognized, if that equates to also being the time that it takes over as the prevalent strain, which I suspect from an epi perspective might be a little different, but once again, that depends on our surveillance from a genetic sequencing perspective.
Well, I think I've been talking with some people. They estimated that it might take up to a year for that new strain to really take over and dominate and replace the old strain. It's unclear. It depends on its actual transmissibility. Now there are different strains that come from all, like it's all over the map with different transmissibility. So here, as I said, for that scenario 4, it's really doomsday, right? So here we assume that basically the new strain took over.
Thanks, Monique. Yeah, I mean, thank you and your team, Alice and Sasha, and I'm sure I'm missing a couple others for doing this. I think this addresses a couple points. One, how much work it takes to really think through a scenario such as modeling impacts of vaccine and vaccine distribution, especially with so many variables just for the logistics aspects. And then you throw on the fact that the virus is mutating, and then, you know, understanding how unique Hawaii is. And then, you know, myself and Monique and anybody else who has, you know, has worked in the modeling and forecasting space, that, you know, these are not meant to be taken as, you know, this is what's going to happen. These are just providing, you know, boundaries in terms of what we might expect to see for different scenarios. And it's just to help kind of, I guess, whet the appetite in terms of what might happen. And it's really not meant to be, you know, forbearing. And if we're off, that doesn't mean that the modeling is incorrect. It's just, once again, there's so many things to account for that we really realistically can't account for. So I think this helps everybody get a better understanding of the impacts of vaccines. So thank you, Monique, and the rest of the team for doing this, especially Sasha. I hope you got some sleep when you're running the code.
The machine is actually running the code.
Yeah.
So the machine is not sleeping, but again, for us, what is important is to get scenario, right? To have people like you or from the Department of Health and say, listen, we're really debating, or what is that, how that decision could impact. And this is where the modeling can come and say, that would like put it off the map, or that would help it control, or that kind of answers.
Yeah, definitely. So for the students and for our partners and also our new partners out there, you know, this is an example of the great work of all of our HiPAM members, and to see previous great work. You know, Marguerite had a great talk with her, and then also she highlighted her students on the genetic shifting, on the mutations. So, you know, we have a lot of expertise to offer, and we're here to support the community and to inform. So it's that time again, and thank you for joining us for this hour. Thank you again, Monique and your team. You can see all the great content uploaded on our website, hipam.org/join. And have a great weekend and be safe. And we will see you guys next week, Thursday. Thank you, everybody.